Hello and welcome to TheMedSurge. And today we are going to discuss about a condition that might sound small but holds immense importance in our health journey. That is diabetes mellitus. Diabetes is a chronic metabolic disorder that affects millions of people worldwide. It's characterized by elevated blood sugar levels due to the body's inability to produce or effectively use insulin, which is created as a result of chronic hyperglycemia with disturbances of carbohydrate, fat, and protein metabolism. First of all, we have to know about the organ that plays a pivotal role in this disease process. This is your pancreas. There are two major types of tissue in the pancreas, the acini and the islets of Langerhans. The acini will secrete digestive juices into the duodenum, which will help you to digest the food that you eat. The islets of Langerhans secrete insulin and glucagon directly into the blood and are crucial for the normal regulation of glucose, lipid, and protein metabolism. The human pancreas has 1 to 2 million islets of Langerhans, and they are organized around small capillaries into which they secrete their hormones. There are three types of cells: alpha, beta, and delta. The beta cells lie in the middle of each islet and they secrete insulin and amylin. The alpha cells are located in the periphery and they secrete glucagon. The delta cells secrete somatostatin. These three cell types are closely related and they can control the secretion of some of the hormones by other hormones. What did I mean by that? For instance, insulin can inhibit the glucagon secretion, amylin can inhibit insulin secretion, and somatostatin inhibits the secretion of both insulin and glucagon. Insulin is a small protein which is composed of two amino acid chains connected by a disulfide linkage and a connecting peptide, which is also known as the C-peptide. In a normal person, the blood glucose concentration is narrowly controlled, usually between 80 to 90 milligrams per 100 milliliters of blood each morning before the breakfast. When you eat, this concentration will increase up to 120 to 140 milligrams per 100 milliliter during the first hour, but the feedback systems will return this blood glucose concentration rapidly back to the normal level, usually within 2 hours after the last absorption of carbohydrates. This is how it happens. The glucose molecules will enter into the beta cells via the glucose transporters, also known as GLUT2. This glucose is then phosphorylated to glucose 6-phosphate by an enzyme called glucokinase. The glucose 6-phosphate is subsequently oxidized to form adenosine triphosphate, which is also known as ATP. ATP is the main energy source of the body. This ATP will inhibit ATP-sensitive potassium channels of the cell, and the closure of these potassium channels will depolarize the cell membrane, thereby opening voltage-gated calcium channels. These calcium channels are sensitive to changes in the membrane voltage. This produces an influx of calcium. So when calcium ions enter into the beta cells, they stimulate the fusion of insulin-containing vesicles with the cell membrane, and they secrete insulin into the extracellular fluid by exocytosis. Where does this insulin go once it is in the blood? Insulin will be transported to the liver, muscles, and adipocytes, which are your fat cells. Insulin will bind to the receptors on the liver cells and translocate multiple intracellular vesicles to the cell membrane, which carry multiple molecules of glucose transport proteins. These glucose transport proteins will facilitate the glucose uptake into the cells. The liver stores glucose in the form of glycogen, and when the liver storage is filled up with glycogen, it promotes the conversion of this excess glucose into fatty acid, and it is then stored in adipose tissue as fat. In muscles, it's stored as glycogen. When food is not available and the blood glucose concentration begins to fall, insulin secretion decreases rapidly and the liver glycogen is split back into glucose, which is then released back into the blood to keep the blood glucose concentration from falling too low. To convert glycogen back into glucose, we need the other hormone called glucagon. Glucagon is secreted by alpha cells in response to reduced blood glucose levels, and it will break down the liver glycogen in a process called glycogenolysis. It will also increase gluconeogenesis in the liver. Both of these effects greatly enhance the availability of glucose to the other organs of the body. In summary, the pancreas has three types of cells, alpha, beta, and delta. When blood glucose rises, insulin is secreted from the beta cells, which results in increased glucose uptake in the cells. And when the blood glucose is low, glucagon helps to increase the blood glucose levels by converting the stored glycogen into glucose. Now let's talk about the pathophysiology of diabetes. The cause of clinical diabetes is always a deficiency of the effects of insulin at the tissue level. Primarily, there are two types of diabetes, type 1 and type 2. Type 1 diabetes or insulin-dependent diabetes mellitus is due to an insulin deficiency caused by autoimmune destruction of the beta cells in pancreatic islets. Type 2 diabetes or non-insulin dependent diabetes mellitus is characterized by the dysregulation of insulin release from the beta cells along with insulin resistance in the peripheral tissues such as skeletal muscle, brain, and liver. In addition, some cases of diabetes are due to diseases or conditions like chronic pancreatitis, Cushing syndrome, and acromegaly, and these are classified as secondary diabetes. One of the key features of insulin deficiency is decreased entry of glucose into the tissues. When insulin concentration is reduced, the glucose uptake from cell is also reduced, and the peripheral utilization is also decreased. Because of the excess glucagon, the liver will increase its production and release glucose to the blood. This results in hyperglycemia. This excess glucose will be removed in the kidneys via urine, which leads to a high glucose content in the urine. This is known as glycosuria. Since glucose is an osmotically active substance, it will also remove water along with it, leading to osmotic diuresis. And as a result, these patients will have dehydration. This dehydration will lead them to drink more and more water, which is known as polydipsia. The cells are deprived of glucose, so appetite is stimulated. So these patients will eat a lot, which is also known as polyphagia. Until then, new glucose is formed from protein and energy supplies are maintained by the metabolism of proteins and fats. So because of this, patients can also have weight loss and debilitating protein deficiency even though they eat a lot. Fat catabolism or the breaking down of fats is increased and the system is flooded with triglycerides and free fatty acids. Now, these catabolic pathways will result in the production of acetyl-CoA, but as they are overloaded, they can't handle the excess acetyl-CoA that is formed. In the liver, this acetyl-CoA is converted to ketone bodies, mainly known as acetoacetate and beta-hydroxybutyrate. The gradual accumulation of ketones will eventually lead to metabolic acidosis, and eventually it will lead to coma and death. So in a summary, when there's an insulin deficiency and a glucagon excess, there will be a decreased glucose uptake, an increased protein catabolism, an increased lipolysis, and that will lead to hyperglycemia, glycosuria, osmotic diuresis, increased plasma amino acids, increased plasma free fatty acids, ketogenesis, ketonuria, and ketonemia. And all of these effects will finally result in dehydration and acidosis. If untreated, the patients can go into coma and death. I hope you guys learned something today. And if you did, please hit the like button and comment your ideas. And subscribe to my channel for more content like this. And as always, thank you for watching. I'll see you on the next video.